everybody. My name is François Boschu, and I'm the co-chair actually of Task Group 109, which is a task group from the ICRP that deals with ethics in radiological protection for medical diagnostic and treatment. And I'm really glad to have you all here today. Apparently about 700 people registered, probably less will finally attend, but it's a really great pleasure to have you here. You all received the program, so all the people who will speak are actually members of the task groups. And as you may have noticed in the program, we want to first do all the presentation and then answer the question that you may have. In practice, the question will be made only with the Q&A function that you can find at the bottom of your page. Depending on the language, it should be written Q&A. I have a French version which is written Q and R, but you should have maybe something that is similar in your own language. So I think I will present the different presenter as soon as they will talk, but what you can already know is that most of the task group is currently present, and if we do this webinar right now, it's because the report is under public consultation, and we would like to have as more feedbacks as possible. And I will give the date of the deadline for the feedback for the public consultation, but you are all encouraged to make any comment that you would like to make. Okay, so that's my introduction, and I'm actually the first one to present, and hopefully it should be good like this. So normally you should be able to, hopefully, I have two screens, so I'm not sure that can anybody from the panel confirm that everything is shared correctly? Okay, thank you very much. So these are my first slides. So I'm doing the introduction. That means that I'm going through the main parts of the report, and I will directly tell you who will speak after me, because we thought it would be much better to present the great outline of the report so everybody knows what we are talking about, and then we will go back in the details. So there will be some small overlaps, but we think that some overlaps should be good actually. Okay, so let's start. Maybe the first thing I would like to do is to tell you who is and was in the task group. So here you have all the names, and just to let you know, well, I need to have the laser pointer. Here is it. It is. So here you can see the names of the people, and you see the specialties of the members. So we have several people who know a lot about ethics. We have 3 medical doctors. We had 1 RTT, and maybe too many. I'm one of them. A lot of physicists. Physicists like to say that they know a lot of things, but that's why there are a lot of physicists here. Before going to the main points of the report, I'd like to say that this has been presented many times throughout the previous years in order to have as much feedbacks from the stakeholders as possible. So here you have a series of conference meetings in which this report was presented during its writing. And as I said, the report is currently under public consultation, and you will have until August 11th to give your feedback. So what is the mandate of the task group? Well, it is to develop an ICRP publication, you can imagine, that present the ethical aspects in the use of radiation in medicine. And actually, there is already one document from ICRP, publication 138, that deals with ethics in general, but our task group was to deal with ethics in the specific case of medicine. And we want to build on what exists in publication 138, that's clear. but we enter a field in which ethics is already really present. So we definitely have to be very modest if we speak about ethics in medicine, because ethics in medicine has a long history, very long, until antiquity at least. And ICRP, even though ethics has been present from the very beginning, only made it very explicit in 2018 with publication 138. So we have to take into account what is already here in ethics in medicine, but we think that we have some specificities within the radiological protection community that can be useful for medicine also. So that means that the main goal of this publication is indeed to bridge the gap between the medical community and the radiological protection community. So I will present you the outline of our report step by step. I more or less did the chapter 1 right now. And in chapter 2, we will deal with ethics in radiological protection. That means the theoretical basis of ethics in radiological protection. And today, Frido Salzer will present you with the details, in particular describing the values that we choose. But right now, in my introduction, I just want to give you a broad view of what is actually present. I told you that biomedical ethics has been existing for a long time. In this framework, there are 4 principles: beneficence, non-maleficence, justice, and autonomy. And more recently, there are some values, or actually principles in medicine that came to be more and more present: solidarity, precaution, empathy, honesty. Once again, Frido will present this. And in publication 138, we couldn't use the word principle because the principle in radiological protection means something very special, as you know. Right? Justification, optimization, limitation, these are the principles of radiological protection. That's why actually we are using the word value. But you see that you can recognize the same concept or similar concept as what we have in biomedical ethics. And apart from the 5 core values, we also have procedural values, inclusiveness, accountability, transparency, that exist in publication 138, specific for radiological protection. So the first thing we had to do was to make some cleanup of this, because if we want to speak the same language with our colleagues in medicine, then we need to have we need to make sure that when we use a word, we mean the same thing as they do. And actually, for the first ones, it was quite easy. They were exactly the same names and the same meanings. Then we thought that with justice, we could put solidarity. Clearly, we thought that could be put together. Dignity and autonomy, as Frido will explain more in detail afterwards, we also thought that this should be put together. Prudence and precaution, the same. And inclusiveness and empathy, the same. And finally, accountability, transparency, and honesty have some very common points that, again, Frido will explain in a bit more details afterward. So that will be the first part of our report, chapter 2. Then in chapter 3, that will be more discussed more in details by Sheko Kuhihara-Sayo, we actually describe what are the more recent development in biomedical ethics that could have a link with radiological protection. And she will describe this in more detail. And then we have a chapter which is a little bit more related to the practice, but still quite theoretical. It's chapter 4. And in this chapter, we will not present it in details. I will just give you some flavor of chapter. I think somebody has his microphone on, so can you turn it off, please? Okay. So in chapter 4, we want to make sure that we have this link between the medical professional and the radiological protection professional can speak the same language. So we have in this chapter something that makes the link in both ways. So in one of the sub-chapters, we talk to those who know a lot about ethics to make sure that they can get some information from those who know more about radiological protection. And in particular, For instance, we explain the meaning of stochastic effect, tissue reaction, all this in the context of ethical values. The particular factor that affects radiation sensitivity, depending on your age, your sex. There are also some individual sensitivity that have some link with ethics, and all the aspects about uncertainties. We know a lot about radiation effect, but we don't know everything. So we have to take into account the uncertainties when we discuss with the patients. And on the other way, we also want to make sure that those who know more about radiological protection can learn some things from those who know a lot about ethics. And that's why in this subchapter, we speak about the specific aspects of medical use of radiation. For instance, contrary to what is done in the nuclear power plant, for instance, the exposure is deliberate. The person who gets the dose has to give his or her informed consent. So all these points are really specific to use of ionizing radiation in medicine and have a direct link with ethical values. Okay, and there is also a link with the famous principles of radiological protection that I just mentioned before. So that's chapter 4. So that's more or less the end of the very theoretical part of our report. In chapter 5, we clearly make the link between the theory and the practice. And Lynette Reid will actually present this part in more detail. And in this chapter 5, we will talk about sensitizing questions. Sensitizing question, I'm sure she will explain that much better than I could. But my understanding is that we have ethical values, we have real situation, and we need to have some tools to help us to find out where the ethical values are and where some dilemma may be found. And Lynette will present a way to help us to find where the ethical values and possible dilemma can be found. And then Jim Malone will explain us the method that we propose to teach or to analyze real situation from an ethical perspective. So he will present this in detail. I think this is more or less at the center of our report, and that will allow us actually to present practical example in the field of medical imaging, diagnostic, and in the field of therapy. And this will be done by Jim and by Mary. But just in a few slides, what is this method? This method consists in presenting scenario in just one page. 1/3 of the page describes a scenario. In the center of the page, we'll have what we call the table of compliance. That means we will analyze this scenario from an ethical perspective, and we will actually give smiley or frownies according to the fact that we comply or do not comply with some ethical values. And then we will explain why we put those smileys and frownies for this given situation. But again, Jim will explain that in much more detail. And we will have actually 11 imaging procedures, 10 procedures in therapy, and we wanted to cover a wide range of situations. Obviously, we cannot cover all of them, but it's just to give some example of different practical applications that we find in medicine. And finally, if we want to make sure that the practitioners know about ethics in medicine, in radiological protection in medicine, we need to make sure that people are educated. And that's why we have the last chapter that deals with education and training in ethics. And that will be presented in more details by Kimberly Applegate. And she will give some details, but I just wanted to mention that we based ourselves on the Bloom taxonomy, because there are different levels of competences when we teach. The most basic level is the level of remembering. So if you just remember some point that I just presented, you are at the first level. If you manage to understand what I'm just saying, you are at the second level, which is good already. I hope I will manage to have this. But then if you understand it's not sufficient, if you need to apply it, then you need to be able to analyze, you need to be able to evaluate what is the situation. And finally, you need to be able to create in this field. And in our report, we just decided to have three levels: the level which we call knowledge, the level which we call skills, so the ability to apply this knowledge, and finally the level of which we call competencies, which deals with attitudes and behaviors. And Kimberly will go into more details, but I just wanted to show you one example. We proposed a relatively long curriculum to teach ethics in medicine when we use ionizing radiation, but just a small example with the three levels that I just presented: knowledge, skills, and competences. And just for the chapter about core and procedural values of ethics in radiological protection in medicine, just an example: at the level of knowledge, identify the core components of dignity and autonomy. So this is just knowing something to be able to describe some concepts. At the level of skills, we have to be aware of the fundamental human rights, that dignity and autonomy and privacy must be respected. And at a higher level, for instance, we need, if we have the right competence, we need to be able to support the patient when they make a decision regarding their treatment or their diagnosis. Okay, so that's all what I wanted to say about the global structure of our report. So in summary, we hope that this report should help the medical and the radiological protection professionals to interact with one another. Our methods, as you will understand more deeply during this afternoon or this whatever, depending where you are, will be that, well, we propose a method to teach and to analyze a situation from an ethical perspective. Clearly, the first part of the report requires some intellectual efforts, because there are some concepts that are not easy to grasp, but we hope that we manage to present them in an understandable way. And it's not only theoretical, but it's also practical in the second part of the report. And to make sure that we have a high probability to reach this goal, we included a large part on education and training in this report, and hopefully that will be also practically usable for those who teach in this domain. And finally, I wanted to mention that throughout our report, we put some key messages all around the text in order to show what is really important in our report. So the key message we want to make sure that you grasp, and we put them throughout the text in order to make sure that you can find easily where are the more detailed explanations. So that's all what I wanted to say as an introduction, and I will then give the floor, as I said, to Frido Salzer, who will actually present what is really important in chapter 2. So thank you very much for your attention. So that means, Frido, you can share your screen.
Yes, I will try to do so. So I'm supposed to tell you a little bit about the theoretical background on how this new publication will be based on the former publication 138. So it's about the general ethics of radiological protection. In this chapter 2, we look at the background, at the principles or the values that publication 138 has proposed. And also then we look at the interpretation of these values in radiological protection on the one hand, and in biomedical ethics on the other hand. So where exactly are the relationships between the two? I cannot move these now. Or can I? Yeah, okay. So 138 was the first publication of ICRP to focus on ethical considerations, on the ethical foundations of the system of radiological protection. It was, of course, not the first publication to ever address ethical issues. There were a few others earlier, but this is the first one that is dedicated to ethics. It was supposed to consolidate the basis of the recommendations of the ICRP, to improve the understanding of the system from an ethical point of view, of course, and also to provide a basis for communication on radiation risk and its perception. Next, please. It aimed at a minimum set of values, so we didn't want to have 20, 30 different values there, but a minimum set of values that would be relevant to the system of radiological protection, that would stand the test of being applied to current and foreseeable problems, and if possible with sensible results that will be of particular importance today with the application of the system to medical questions. And also it was important for the task group that prepared 138 that the values proposed here would be common or at least acceptable in the widest possible range of cultures, so that it would not be perceived as an exercise in Western philosophy and European philosophy, let's say, although of course it has similarities in many ways with systems of Western philosophy, but it should be such that it would also be acceptable to people from other parts of the world. Next one, please. So these are the core ethical values that ICRP identified. The idea was that these are not new, these are not imposed on the system now, but they are values that have always been there, maybe to different extents during the history of ICRP, but they can be identified in different phases of the development of the recommendations of ICRP. The first one is beneficence and non-maleficence. So beneficence means promoting or doing good, and non-maleficence means avoiding doing harm. So these two, of course, belong together, and you will later see that they are in a particular relationship, but they are presented as one value here. We want to do good and avoid harm. The second very important core value is prudence. We want to make informed and carefully considered decisions, choices, without full knowledge of the scope and consequences of an action. So we want to be cautious, yes. We have to assume that even small doses of radiation could have an effect. But on the other hand, we want to stay reasonable. We want to apply this idea reasonably. We want to reduce doses as low as reasonably achievable. So we have to be well informed. We have to carefully consider our choices in view of what we know and what we don't know. If we don't know the full scope and consequences of an action, we still have to try and be prudent and cautious on the one hand, reasonable on the other hand. Then we want to be just and fair. So justice is seen here mostly, not exclusively, but mostly as fairness in the distribution of advantages and disadvantages. We don't want one particular group of people to carry the brunt of the risk, radiation risk, and another group to have all the advantages. So this has to be fairly distributed. And the fourth value was called dignity. You will later see that this is a very general term, and in medicine it's more specifically explained. So dignity is meant as the unconditional respect that every person deserves, irrespective of personal attributes or circumstances. Next one, please. There were also procedural ethical values, so values that we would apply in the practical field. We want to be accountable. That is the obligation of individuals or organizations who are in charge of decision-making to answer for their actions to all those who are likely to be affected. We want to be transparent, especially in our communication. So transparency means the accessibility of information about the deliberations and decisions concerning potential or ongoing activities, and the honesty with which this information is transmitted. And we want to be inclusive. We want to ensure that all those concerns are given the opportunity to participate in discussions, in deliberations, and in the decision-making concerning situations that affect them. These, the quotes that I have presented here are quotes from the new report, from the suggested text of Task Group 109. The wording in the original publication 138 is a bit different, but of course the content is the same. Can we continue, please? So we have this setup. If you put it in a table, the 4 core values and the 3 procedural values, and then we note if we come from a medical background or we know something about applied ethics, we note that there are some similarities, as also Francois was mentioning, with the system of biomedical ethics, the so-called principles of biomedical ethics. Maybe you can give us the next slide. Adds another table there on the right side. The ethical values, or actually Beecham and Childress that first proposed them, were speaking of principles, which, as Francois said, we don't use in radiological protection because principle means something else. But you see there is some similarity. There is here respect for autonomy, which has something to do with the dignity. There is beneficence and non-maleficence, and there's justice. And just the order is different, the order in which usually it is discussed in biomedical ethics. So we have to maybe reorder it. Can you give me the next slide? I think that should do it. Should do reordering. Yeah. So TG109 decided that we would follow the order more according to what what medical people are used to. So we would put dignity first, because respect for autonomy is first in the biomedical field. Then we put together beneficence and non-maleficence, which are 2 independent values for biomedical ethics. Biomedical ethics doesn't speak about prudence. It may be mentioned somewhere. I don't think even there is any mention in the book of Beecham and Childress, at least not in the original one from 1979, about prudence. So that doesn't have a corresponding value in biomedical ethics. And justice, of course, is important for both. So we thought, yeah, there is this parallelity. So what do we do when we suggest the list of core and procedural values from ICRP to people working in the medical field? And we came up with the idea that we would not speak about parallel systems of values, but we would add to the list of core values and procedural values a list of interpretations, additional interpretations that would be more relevant for the medical context. And I think that is what is done on the next slide, or in the next slides. So I go one by one. The additional interpretation of dignity, the more concrete application of dignity, is this concept of autonomy, or in biomedical ethics, the respect for autonomy. That means the every person, especially our patients, have a certain dignity, and that means that they should be taken seriously. They should ideally be decision makers in their own case. Of course, we have to consult with them. We have to suggest to them certain possibilities, but the patient is the autonomous decision maker. Beneficence and non-maleficence, maybe give me the next slide, because here is the wording of our report. We see autonomy as the capacity of individuals or groups to act freely, decide for themselves, and pursue a course of action in their lives. Next one, please. Beneficence and non-maleficence are known to biomedical ethics. They are central to biomedical ethics. And the idea in biomedical ethics is, of course, that they have to be balanced against each other. Sometimes maybe the idea of beneficence is more important. Sometimes the idea of non-maleficence is more important. In surgery, for instance, you can't do benefit. I can't have benefit if you don't have, you don't hurt the patient. You have to make a cut into the skin of the patient and through some tissues. And the same is the case in radiotherapy. You want to do good, you want to have beneficence, but you also do some harm. You have to expose healthy tissue around the tumor or in front and after the tumor, behind the tumor. So we do have the need of balancing benefits and risks. Maybe that doesn't have to be, we don't have to focus again on that, but the group found that it would be better to mention it here as an additional point. Then prudence, can you go on? The next one gives you the wording of our, so assessing procedures that with respect to the benefits and risks as they relate to the patient population and in individual patients. Next one. Prudence is coupled here with or correlated with precaution. Although I said before that the ICRP didn't want to really present this value just as precaution, because that would mean that we don't take into account, or we don't really always think adequately about reasonability. But still, in the medical field, maybe the concept of precaution is something that is more familiar to people. So we put it here as a paired value to prudence. And the wording is as follows. Please give me the next slide. Precaution means that measures are taken to prevent or reduce risk in the absence of scientific certainty. So we are not clear, we are not 100% certain about the effects following exposure to 10 millisievert or 2 millisievert, but we will take measures, we will do everything reasonably achievable to reduce these exposures. So we will take measures. And the next one, please. Justice, as was mentioned before by Francois, is paired here with solidarity. On the one hand, we want to be fair to different groups in society, but maybe also sometimes we need particular attention to vulnerable groups, vulnerable patients, and that means solidarity. Give me the next slide. There's the definition that we used in the draft document. Solidarity is the consideration of the common good and the societal structures that ensure it, as well as interpersonal relations of recognition, reciprocity, and support. So it goes beyond justice, beyond weighing just the benefits of and risks of different groups, but it looks more at the greater whole. What about the procedural values? Next slide, please. Accountability and transparency are paired here with honesty, although honesty is mentioned by ICRP in its definition of transparency. But again, we thought that it should be mentioned here because it's something that is more widely used, perhaps as a concept or as a term in medicine. Beecham and Childress, the gentlemen that developed this system of the principles of biomedical ethics, speak of veracity, but okay, the group settled on honesty, and the definition is in the next slide. Honesty is the professional and personal commitment to candid and truthful sharing of information. So we saw that as a useful addition for the clinical context. And finally, we have inclusiveness, which the ICRP explained very much with the concept of stakeholder involvement, so the people that have a stake in the problem that comes up with radiation exposure should have a say, should be part of the decision making, which is also closely correlated to dignity, of course. And here the group thought that empathy would be an important concept that is paired with inclusiveness. Empathy, in the next slide, you see, is sharing another's emotional response and or understanding. So there is different forms of empathy. It could be emotional response that is shared, or the understanding, conceptual understanding, and the understanding of their feelings and perspectives. So again, feelings, emotions, and perspective of the patient should be taken into account. So it is putting yourself into the shoes of the person that you are dealing with, that you are trying to make a decision with. You include them in your decision making, but also you try to see things from their perspective, so that you really that this inclusion makes sense. So the next slide just gives you the full table, where you see on the left hand the values of ICRP 138 in a slightly different order. I repeat that from the original report. And then the order is more catered towards people coming from the medical field. And then with every core and procedural value, we have an additional interpretation that comes from the medical field. And we hope that with these combinations, we will be able then to address the scenarios that Francois already mentioned, and Jim and Mary will later introduce. Thank you very much.
Okay. Thank you very much, Frido. I think that was really clear. Again, the question can be asked with the question and answer Q&A button at the bottom. You may even, if you look at it, you will realize that one question was already answered. So that means that right now we can move with the third speaker. The third speaker is Chieko Kurihara Sayo, and she will present in a bit more detail what is present in chapter 3, as I just described before. So Chieko, you can share your screen. Thank you.
Thank you very much for your introduction. So I will share my screen. Slideshow. Is it okay?
Perfect.
So thank you very much. So in chapter 3, we discuss about the practical implementation of my biomedical ethics. Here, we will learn key developments in clinical practice that implement the core and procedural ethical values. So this is the contents of chapter 3. In providing patient care, we often face questions not just about technical skills and scientific knowledge, but also about values, human rights, and responsibilities. The previous chapter presented by Fredo discussed the core ethical values and the procedural values of radiological protection. And this chapter will discuss how we can implement these values in the actual clinical practices. Points of discussion are listed here. First, we will discuss about the professional oath and codes of ethics. Historically, biomedical ethics was expressed in physician's oath, while the Medical Association's Declaration of Geneva was adopted in 1948 and last amended in 2017. It provides a modern perspective to the ancient Greek Hippocratic Oath, emphasizing humanitarian aspects of medicine. The Geneva Declaration by WMA describes physicians' pledge, including respect for the individual patient, as well as doctor's own health and well-being in order to provide care of highest standard. The WMA has also issued a series of ethical and social policy documents on various topics, for example, patient right, patient safety, end-of-life care. ICLP issued 2014 their Code of Ethics. Some other professional societies related to radiological protection have issued their own Code of Ethics. So you should consult with those of the societies you are engaged in. So next, we will discuss about the role of ethics committee. There are many types of committees of the level of international, national, or institutional. So international ethics committees have been established by professional bodies such as World Medical Association, Council of Europe, UNESCO, as well as WHO. Their role is to provide bioethics policy formulated as international agreement. UNESCO recommends establishing national and institutional ethics committees in its Universal Declaration of Bioethics and Human Rights issued in 2005. National ethics committees advise government, national bodies or institutions, and inform the general public, providing national policy on newly arising ethical issues. Role of institutional ethics committees is more directly related to ethical dilemma you face in everyday's ordinary practice. Healthcare facilities may have clinical ethics committees or ethicists, sometimes called ethics consultant, who formally consult on ethical dilemmas. Ethics committees are independent, interdisciplinary teams that provide education, policy development, and case consultation. Ethicists or ethics consultants will provide consultation for each case, and sometimes they request for discussion in ethics committee. In case ethical issues concerning use of radiation arise, radiological protection experts may be requested to participate in such consultation on an ad hoc basis. In such situation, if such situations are common, radiological protection expert may be included as a member of the ethics committee. So in summary, national and international ethics committees provide policy guidance for emerging ethical issues. Local or institutional ethics committees provide guidance and education on specific dilemmas in practice. Next, we will discuss about the clinical practice developments, considering the topics of informed consent, privacy protection, end-of-life care, professionalism and financial influences, and radiological safety culture. All these practices will be implemented, integrating and balancing ethical values, which ICLP clarifies in this and the previous reports. So first, about informed consent. Legally, the requirement of respect for autonomy derived from respect for dignity has been specified in the requirement to seek and respect patients' informed consent or refusal of medical interventions. Patients have to be informed of the risks and the benefits of a proposed treatment or a diagnostic intervention and its alternatives, including the alternative of doing nothing. Patients are free to make a decision without coercion. Recently, shared decision-making model in patient-centered care, patients are asked their preferences and clinicians actively facilitate a two-way exchange of information. Shared decision-making for diagnostic and therapeutic procedures is often a key element in radiological protection in the clinical context. There is growing awareness toward improving transparency by communication and education about the risks and the benefit of the intervention. It should be noted that Imaging Wisely and the Imaging Gently campaign provide materials to assist in communication of risks and benefit. So practical approaches to respect for autonomy in a situation where patients lack the capacity for consent have been defined by laws in many countries. Healthcare professionals must be aware of their legal regulations and cultural context. They should also be aware of the evidence that even hospitalized patients with psychiatric conditions often retain capacity for medical decision-making. We also have to consider about vulnerability. The majority of patients referred for radiation therapy have been diagnosed with cancer. This means that they are at a vulnerable point in their lives. Research has shown that significant percentage of patients have a negative perception of radiation therapy because of media reports about severe side effects and poor outcomes. However, another research reveals that at the post-treatment, the vast majority of patients were more positive with regard to treatment. It is very important to provide information of risks, burden, and the benefit of radiotherapy. For a pregnant woman or a woman of childbearing age, full information of risks of high-dose diagnostic procedures or radiation therapy should be provided. It means the information on the risks to the fetus, the possible effect on continued pregnancy, and the long-term well-being of the child, as well as effect on childbearing capacity. It should be noted that fetal doses below 100 milligray should not be considered a reason for terminating pregnancy. The question of involving the pregnant person's partner or father of the fetus in decision-making can be a sensitive issue, especially in the context where women's rights are not well respected. In any case, shared decision-making with the family and the medical team, including radiation experts, is particularly important. The developing capacity of children is recognized in the process of seeking their assent, which means willingness of receiving interventions based on understanding of the risks and the benefit according to their capacity of understanding. The extent of the parent involvement in consent for pediatric patients depends on the age and the maturity of the patient. You should be careful because the manner and the scope may differ in different jurisdictions. Patient privacy and confidentiality are expressions of respect for human dignity and autonomy and have a long history of biomedical ethics. The general physical layout of the imaging or radiotherapy should ensure the patient's bodily privacy. Recently, expanding use of artificial intelligence and machine learning leads to standardization and optimization of imaging. As technology and research practice evolve, we should more consider about privacy protection in the settings of utilizations of large amount of personal information. At the end of life, reducing stochastic effects of radiation becomes less important. At the same time, imaging that is painful and disruptive for very ill and dying patients should be avoided when it will not benefit the patient. The values of non-maleficence and prudence should be considered in these cases. Advanced care planning, ACP, has recently been formalized in various regions as a process where patients can develop an explicit plan considering a future where they come to be incapable of expressing their own will. In radiological protection, conflict of interest may include physician ownership of diagnostic and treatment equipment, or personal benefit from referral relationships. In radiation therapy, the increased financial benefit can result in patients having an extended course of treatment. The common ethical goal is to ensure that clinical decisions are made in the best interest of the patient and not for the financial gain of health professionals or institutions. At the conclusion of this chapter, we mention important concept, radiological safety culture. Radiation safety culture is harmonious with the broader concept of patient safety. It can be understood as a combination of habits and knowledge of radiological protection in all its aspects for workers, patients, population, and the environment, and in all exposure situations, combining scientific and social dimensions. Culture is a product of individual and group beliefs, values, attitudes, perceptions, competencies, and patterns of behavior that determine the organization's commitment to quality and patient safety. Because ethics is therefore clearly a part of a radiological safety culture, appropriate education and training in ethical values is extremely important. So thank you very much for your attention.
Thank you very much, Chieko. Again, if you have questions, do not hesitate to ask them in the Q&A. So our next speaker will be Lynette Reid. She will actually directly speak about chapter 5, because as I said, chapter 4 is interesting, that's true, but we didn't want to focus on this chapter. And Lynette will talk about sensitizing questions. So Lynette, you have the floor.
Thank you, Francois. Let me get my share going. Hello, everyone. Thank you for attending today's session. My name is Lynette Reid. I'm a bioethicist in the Department of Bioethics, Faculty of Medicine, Dalhousie University in Nova Scotia, Canada. I'll keep my comments and explanation very short. I'm just explaining a short part of the report. And let me go back to my first slide. So far you've heard about the background chapters, the source of the project, the genesis of the project, and the goals of the project, and the background chapters outlining core values and additional values and clinical interpretations of the core values for ethics in radiological protection in patient care. And you've heard a chapter that's a real overview of recent developments in clinical application of core values. Now, as people work through those chapters or make use of those chapters, they'll have dealt with quite a bit of substantial explanatory material, which is written at a very accessible level, we hope. We look forward to your feedback on that. And that prepares people for what's to come up in chapters 5 and 6, which is practical exercises in using these values to think through clinical scenarios. So Jim is going to be explaining that to you in the next section, how that practical exercise of using the core values and additional values to interpret and guide decision-making in clinical scenarios, how that goes. I'm going to explain to you what this table of sensitizing questions does. So imagine you've read the 25 pages of ethics materials and then chapter 4, which Francois has skipped over here, which is another maybe 20 pages of materials on radiological protection principles and on the use of radiation in medicine and on uncertainties and on harms and benefits. Now you're going to actually take clinical scenarios and analyze them using these core values and additional values. And this table is just here to kind of bridge the earlier chapters and to help you do the exercise of chapters 5 and 6. So it takes the core ethical values and there's a big leap. So you've got from chapters 2 and 3, you've got definitions, examples, history, recent clinical practice, best practices, and you have a table of definitions of the core and additional values. And now when you look at actual clinical scenarios, it can sometimes be confusing how to apply those core values or how to perceive them or how to interpret them. For example, a single decision point in clinical care will often involve more than one value in very interrelated ways. Like just think about the basics of what it is to share information with patients and seek informed consent. Obviously, that's guided by principles of dignity and autonomy and respect for the freedom of the individual patient. It's also guided by non-maleficence, like the patient might be the best source of information about what harms might matter to them, and beneficence. If you want to do clinical good for the patient, you have to know what their goals of care are and allow them space to reflect on their goals of care. So your beneficence won't be very beneficent. The good you are doing patients in medicine won't be as good as it can be unless you're engaged in that shared decision-making with patients. So autonomy, beneficence, non-maleficence, and justice, because it's not fair to deprive people of choice. Justice comes into play, and because patients have different situations and may have more or less autonomy in their lives to exercise choice, they may look to more or less support from their clinicians to exercise choice when you're looking at vulnerable populations. So it all comes together in that one thing. So to help people make that interpretive leap and to help prompt and remind them of all of the reading they've done up to this point when they go to do the exercises, we have a table of sensitizing questions. They're examples, they're not exhaustive, many more examples could be considered. So for example, for dignity and autonomy, these 4 questions are a selection of the many examples that we give. And this is where you'll see respect for privacy and confidentiality highlighted in the report is in the interpretation of dignity and autonomy. I'm not going to talk through all of these because I think if I talk through all the examples on each slide, then I'll be taking time away from the discussion. And I appreciate all the comments and questions coming in the Q&A. So for the harm benefit trade-off, have the risks of harm been minimized, but also have they been mitigated? What kinds of harms and benefits are we thinking of, medical or psychosocial? Is there a risk of medicalizing or overdiagnosing the patient? That might be a common concern in diagnostic radiation contexts. And this table of sensitizing questions just helps and prompts people to realize, oh, that's what they mean by beneficence and non-maleficence. That's a good interpretation of that in this context. Prudence and precaution. Have we considered unintended consequences? Have we discussed the relative uncertainties? Have we accepted that the level of evidence that we have is the evidence that we have? And even if it's not the most ideal form of evidence, it might still be important to take it into account in our decision-making. Justice and solidarity prompts people to think that that is about resource allocation questions, who's getting the benefits and who's getting the burdens of a technology. Are technologies financially sustainable? Are there inequitable health outcomes, social determinants of health that matter for the patient in the context in which this application of radiation and diagnosis or treatment is used? Accountability and transparency and honesty, obviously closely tied to autonomy and dignity. This is about sharing the information and sharing the decision-making, but also about when it's not about decision-making, but something has happened and what's the follow-up. If there's been an adverse consequence, if there's been a near miss, if there's been an adverse event or a near miss, how have the patient and family been part of the debrief situation and part of addressing that within the healthcare team, within the institution, within the system, so that it doesn't happen again. Inclusiveness and empathy. There's already been some discussion in the Q&A about how empathy and inclusiveness are understood. So this gives you some questions that help you prompt you to understand, well, are you taking the patient's concerns seriously, even if you don't share those concerns? They're the patient's concerns. Are you empathic? Are you including the patient with all their concerns in the decision-making process? So that's a quick review of what that table looks like and how it can be used in now what is going to be explained to you in the next chapter. Thank you very much.
Thank you very much, Lynette. I hope everybody enjoyed as much as I did. For the next speaker, what I need to share. Yes. For the next speaker will be Jim Malone, and he will actually present the method that we propose to analyze practically a given situation, and he will also present some specific cases on diagnostic imaging. So, Jim, you have the floor.
There we are. Okay, good afternoon all, and greetings from a pleasant sunny afternoon in Dublin. It's a pleasure to talk about the application of the various values mentioned by Frido and Checo, and indeed to try and talk about the evaluation using the clinical examples. The examples or scenarios we're going to talk about are based on experience, but they're not literally true. Their purpose isn't to demonstrate good practice, and I think it's important to state that. It's to construct plausible, necessarily dramatic situations to illustrate both compliance and non-compliance. The idea is to provide an approach that can be used by those not experienced in making formal ethical judgments. The scenarios are sometimes a little extreme to make it relatively easy to make ethics judgments intuitively, initially at any rate, and to be able to see clear examples of non-compliance, which has considerable didactic value. Once that's achieved, it will be easier to look at more complex and realistic and demanding situations. The report provides an additional tool, as you've just seen from Lynette, and that is the sensitizing questions, which are very helpful when it comes to dealing with the more realistic real-life situations. Now, what are we going to talk about then? Well, very briefly, the values, but they've been very well covered already, so we don't need to dwell on them. And I'll really concentrate on the evaluation, and particularly the scenarios which involve telling the story. In other words, if you have a situation that's a matter of concern, you have to write it down or in some way construct it as a narrative so that you can evaluate each step of the narrative. So you tell the story, break it down, and apply the values one by one to the story as you see it. And that allows a very, very telling evaluation of what's going on, and allows ethics to become a kind of lens with which you can view what's happening. The values I won't go through again, but you've been through them. The 6 value pairs several times now, and they're the value pairs that we'll be making judgments on. And when we come to make judgments, we look at we construct a table, which Francois referred to as a table of compliance, which is a very good term for it, but it's also a table of non-compliance. So we have 3 rows. The first row presents the values across the top. all 6 of the value pairs, going from dignity and autonomy to inclusiveness and empathy. Now, there will be cases where you don't need to use all 6, where it's clear that one value isn't relevant, or maybe 2 values, but you use whatever number of the 6 are required to judge the situation. And you look at if there's compliance, and you also look at if there's non-compliance. And you can have both compliance and non-compliance there in any situation, can be there simultaneously. And this shouldn't be a problem for anybody. It certainly shouldn't be a problem for physicists who deal with uncertainty and on electrons being both particles and waves and so on. You can have good people who are also a little bit bad, and that's what we're dealing with. The scale used is really a very simple one, either complete compliance or partial compliance. Complete compliance gets 2 smileys, partial compliance gets 1 smiley. We may have nothing to say about that particular value, or you can have complete non-compliance, partial non-compliance, or you've nothing to say, or we've nothing to say about it. And there are, of course, other ways of representing this. One of them is just to have yeses and nos, but the system used in the ICRP report is to use the smileys. Now, initially, I would suggest if you're trying to do this based on back one, using the smileys and so on, I think the best way to approach it initially is to try and do it intuitively, based on your intuition, on the set of values, which I think offer great guidance, even if you're not familiar with them. They're all words that have an intuitive meaning, and on the on your personal moral compass. Your personal moral compass is very important, but it isn't enough. And if you find you're struggling with the values, you can then go to the sensitizing questions. But initially, start and try and get as far as you can based on intuition. And if you go to the value set as Lynette has shown or demonstrated for each of the value sets, you will find lots to prompt you. And after each scenario, I'm going to present just one of the values and the sensitizing questions. By and large, I'm not going to comment on it, but I've highlighted one value that should be, or one question that should be very easy, 1 or 2 questions that should be very easy to respond to. So we'll go to the first of the scenarios, and this involves Professor Brown, Professor Augustus Brown, orthopedic surgeons. He's an orthopedic surgeon, and orthopedic surgeons are often very very confident. They're sometimes very big. You need to be strong to be an orthopedic surgeon. And he's very definite, very paternalistic, a caring man in his own way, but a very paternalistic individual. He has a busy clinic every week in a large university hospital. He has new patients, follow-up patients, people coming in with injuries, and elective patients. And he insists, for good or ill, that every patient coming into the clinic is sent to radiology if they haven't already been there. And he has pre-signed forms given to the nurse to send them to radiology for radiology of whatever part of their body they want him to look at. He won't see the patient without a film folder or DVD or some other radiological record. He reads the images himself because there are long reports in getting or long delays in getting reports from the radiology department. The director of radiology and the imaging medical physicist have advised him against this practice. His response is dismissive, pointing out that the radiology service is the home of long waiting times in the hospital, whereas he runs an efficient, patient-friendly service where he tries to get as much as possible done in the initial visit. So he dismisses reports or dismisses concerns about possible risks from radiation, saying they're largely speculative and they haven't been proven. So he refuses the advice. The hospital is a very important clinic in the hospital, and the hospital allows him to refuse the advice on justification offered by both medical physics and the head of radiology. And he proceeds, and he's proud of the efficient patient-centered service he provides. If you look at this, under 5 of the 6 values, all 6 are necessary, but as the first attempt we're going to do at this, to allow space that you can see, I've only looked at 5. And it scores under the ethics evaluation. There's a lot of non-compliance here. And under any of the values you care to look at, I'll just mention 1 or 2 things that are serious problems. Under dignity and autonomy, the lack of engagement with the patient, who may have had an examination, a radiological examination, even the day before or in another hospital. There's no engagement with the patient on issues like that. That's a serious lack of respect for their dignity and autonomy, and a serious lack of compliance. There's possible significant radiation dose and possible significant risk that isn't reckoned. So this also gives rise to a negative brownies. Under justice and solidarity, it's a relatively poor use of resources, not to these are relatively scarce resources, and other people may well have need of them. So it's a poor there's a lack of equity in the use of resources, and under prudence and precaution, there's obviously a lack of prudential thinking in how this clinic is set up. And finally, under honesty and transparency, there is very little engagement or accountability. There's very little engagement with the patient. But on the other hand, the overall efficiency of the clinic really derives from a significant accountability that Mr. Brown feels towards his patients, and likewise a similar consideration would apply under justice and solidarity. So there is there are positive dimensions to the situation. And here you have one of the sets of sensitizing questions that you could look at in more detail if you want to follow through on that for this particular example. Our second case involves Miss Julie Magenta, who's a woman of about 40. She attends her local hospital for an elective abdominal CT scan, but she has a sense of urgency about it, and she wants it dealt with before she goes on holiday. And she explains this at the reception desk. She's asked if she's pregnant at the reception desk, which is a relatively public area in the radiology department. She's asked if she's pregnant, and she responds no. She states that her periods are fairly irregular, but she knows her situation, and she's quite happy that she's not pregnant. The hospital decides to proceed with the procedure due to the firm no and the sense of urgency that Julie Magenta has. Julie, without having advised the hospital or the radiology department, has been having ongoing IVF treatment, and she's been through several cycles which have been unsuccessful, and she doesn't reveal this at the reception desk because it's a relatively public area and she's sensitive about the matter. Some days later, she visits her obstetrician, who after a pregnancy test indicates that she's probably pregnant. She's delighted with this, overjoyed. She goes home, she's talking to a friend and explains that she's probably pregnant. The friend asked her about the CT scan and is knowledgeable in the area and suggests the CT scan could have been a relatively high dose and might lead to significant damage to the embryo. She's really worried about this. She goes back to the hospital. She meets the radiologist who was responsible for the CT scan. He explains to her that if there's any damage to the embryo, it'll be lost, and that she's at no risk of bringing a damaged fetus to term. So she's absolutely horrified at this, thinking that the CT scan would result in the loss of the embryo, which until quite recently wasn't regarded as a harm in radiation protection. So she leaves the clinic and goes home and is very upset about the whole situation. And how do we evaluate this? And I've done this again with the 5 values, and it's a slightly different value. The last value is the inclusiveness and empathy, which is clearly poor in this situation, particularly in the situation didn't allow for development of an empathetic response to the fact that she was undergoing IVF, or indeed even of the pregnancy question, because of the arrangements or the lack of confidentiality of the area in which the questions were put. There's also a very clear lack of respect for the dignity and autonomy of the patient, both in the reception arrangements and in the manner in which the consultation, when she returned to the hospital, manner in which that was handled. There is a significant possible risk to the embryo, and less to herself, and the risk to herself was warranted as there was a referral for the examination, and again a lack of prudential thinking in the arrangements. And again we have here the sensitizing questions, which I won't stop to talk about. Move on to the next scenario, which will be addressed by Fred Fahy, and it involves a pediatric patient and a somewhat more balanced set of compliance and non-compliances.
Thank you, Jim. My name is Fred Fahy. I'm a medical physicist at Boston Children's Hospital, and I'm happy to present this scenario to you. Susie Rainbow is a happy, active 4-year-old girl who starts to limp, favoring her right leg. She also has a slight fever, so the pediatrician initially suspects osteomyelitis. But they have at his institution where she's being treated, no pediatric radiologist on staff, and they use protocols that are appropriate for a young adult because those seem to be the ones that are closest. Susie cannot really say, she's 4 years old, she can't really say what part of her leg hurts. So they perform an X-ray survey of the whole leg. After several visits and tests, the doctors determine she has neuroblastoma. The treatment for such, which will extend over a number of years. Since she's already received several X-ray studies, her doctors decide that they'll use MR for follow-up imaging, which will necessitate sedation and anesthesia at each imaging session. So, Jim, could you go on to the next slide?
Yeah.
So here is the rankings that are given in the report. I will point out that this doesn't mean that these are the perfect rankings or the correct rankings. It may be that yours may vary a little bit because of how you perceive Susie's case in the context of the patients that you see at your institution and the importance of local values. But I'll just point out a couple things here to consider. The staff tried to make the right decisions for Susie in the beneficence, non-maleficence case, but they did not consider perhaps the risks associated with MR. The use of gadolinium contrast and in sedation and anesthesia over longer sessions and multiple sessions. So they get 2 smiley faces for the things that they do well, and perhaps 1 frowny face for something else that they should have considered. There also, you could consider that there was a lack of most appropriate care for a 4-year-old because there was not really a pediatric radiology program at the institution she was seen at. So she gets 2 frowny faces for inclusiveness and 1 frowny face with respect to justice, because even though she's just 4 years old, that does not mean she doesn't deserve to have full appropriate care at their hospital. There may be even, as we'll talk about in the next slide, some things that are not available maybe at her hospital. Jim, could you go on to the next slide? So I'm going to just discuss very briefly the sensitizing questions in the context of accountability, transparency, and honesty. And what we're mostly focusing on is the accessibility of information about the deliberations and the decisions that were made, and the honesty with which they were shared, and the candid and truthfulness of that sharing. So again, we have a number of questions here. I'll just call your attention to the second one and the 4th one. Have we discussed the additional information that would help the patient for their personal care and decisions? And the 4th one down, have we provided the patient with information about relevant alternatives outside the scope of our practice? So I would ask you just a couple of additional questions there. Did the staff discuss appropriately their limitations in pediatric imaging with the family and the patient. And when deciding to shift to MR, did they discuss the benefits and risks associated with other alternatives, such as, for example, I-123 MIBG imaging, and even maybe later on the therapeutic side, I-131 MIBG therapy, as well as the risks and benefits associated with MR. MR might be the most appropriate choice, but they should make sure that they discuss all this with the patient. So I'll leave that for you to ponder with respect to this case, and I'll turn this back over to Jim. Thank you, Jim.
Yeah, thanks, Fred. And we move on. Oh, my goodness. Oh, that's good. Yeah. Move on to the next scenario, which involves a very successful businesswoman, Eleni Tsakaris, who's traveling on vacation with a friend, and she picks up a free magazine on that offers health tourism products, including checkups in a clinic that includes if you like, a whole health scan, a whole body CT scan. A physician referral apparently isn't needed, and she makes inquiries to the clinic about the full service. And it sounds very interesting. The physician explains everything to her about the tests involved, the lab tests, the medical tests, and the CT scan. The physician also explains that the CT is integral to their assessment and the cancer risks are negligible. The whole body CT scan isn't negligible in terms of dose. And the follow through from that is that she goes and has the tests. It's a one-day setup. And at the end of the day, she gets all the results and everything is fine and she's very pleased. And later, a friend who's knowledgeable in the area explains to her that a whole body CT scan involves a significant amount of radiation, that she's had no symptoms, that she went without, as it were, a referral for this, that she wasn't in any way unwell. This situation, in fact, the evidence indicates that whole body CT scans have no value for an asymptomatic individual, like as described here. The scans are costly, they can lead to potentially risky follow-up exams, and there's a risk of radiation-induced cancer. And also they consume a scarce resource. Most national and international guidelines advise against this, but on the other hand, it's quite common to be able to get this kind of a service in many cities throughout the world. And we haven't really time to go in detail here, but I think it's reasonable. The negative evaluation is very powerful across most of the values here. Under dignity and autonomy, the lack of candid information was a real problem. And didn't respect the patients coming in. There is a harm risk. There is a justice and solidarity issue in terms of equity of access to resources. There's a lack of prudence in planning the services, and problems with both inclusivity and honesty and transparency. So, and again, I'll skip through this, but these are there, the questions, if you have time to look at them. And to wrap up, few final thoughts. We've looked at just 4 out of 11 examples in the diagnostic section of the report. There's many more examples in the report, and there are many examples in the literature in various forms. And I think, as Fred suggested, that those of you who are involved in this are in a clinical cold phase are quite likely to be able to generate very useful examples if you reflect on your own practice. These are not a guide to best practice. They're in fact a guide they're there to allow a skill be developed, to give you an opportunity for thoughtful analysis of something close to day-to-day practice. Telling the story and breaking it down is very important. Putting it together, even writing it down, is helpful. Intuitively evaluate each element of the story with respect to the relevant values, and possibly consider using using the sensitizing questions once you've gotten that far. All of these add to the guidance that you can get from a purely personal moral compass type response to the situation. They'll give you a far better formal response with respect to known values and with respect to particular sensitivities. And they will allow ethics to become a lens that guides your practice and guides your evaluation of situations. And this will bolster the basis for viewing, for the view that our professions are morally sound. And finally, there are 4 open access references available at the end. All of these are available as free downloads and give you a very good background in the area. So thank you, Chair Francois. I'll stop sharing and hand back to you.
Thank you very much, Jim and Fred, actually. So thank you both. Now we are moving to the second part of the scenarios, and Mary, and I don't remember if Jim is also involved, but at least Mary will be involved in presenting some scenario or case example in therapy. So Mary, you have the floor. Thank you.
Okay. Thank you very much indeed. As Francois said, my name is Mary Coffey and I'm a radiation therapist attached to the discipline of radiation therapy in Trinity College in Dublin. So I will share with you some of my thoughts on ethics for radiation protection specifically related to radiotherapy. Do I have the next slide, please? I thought I'd start by actually discussing or reflecting on what radiation protection is in radiotherapy. Generally in the legislation, it's under the umbrella of radiology, but I think we really need to consider how that can be separated out because our focus is really very different. Obviously in radiotherapy, we're delivering a high dose to the tumor, but we're trying to minimize the dose to the normal tissues or the sensitive organs. So I think that makes it intrinsically different to radiation protection in diagnostic imaging. And I think you also have to add in the complexity of your patient population. You know, you may be in a curative setting, which will bring you with one set of ethical values, maybe non-curative palliative setting, where you will look at things in quite a different way. And therefore, with these case studies, I've tried to look at it from that concept of radiation therapy or radiotherapy and applying always the principles of justification and optimization, the same as you would in diagnostic imaging, but considering the ethical aspects and actually trying to follow the patient clinical pathway from diagnosis to follow-up. And within the scenarios, which I'm not presenting today, there's also one on ethical recruitment into clinical trials, which I think is also becoming a bigger issue again in radiotherapy. So the next slide, please. So the first patient is one that I think maybe those of you in radiotherapy might be quite familiar with. And this is where this lady, Anna Fortuna, had a recurrent malignant melanoma on her ankle. Now, this was her 3rd resection. So in that scenario, very much there would be a non-curative intent because obviously this would be likely to have metastasized or to metastasize in the near future. In addition to that, she had an open wound that wasn't healing, and the surgeon didn't feel he could go back and reoperate. There was nothing he could do, so he referred her to radiotherapy. And in a radiotherapy context, this also brings you to the thought that all patients referred for radiotherapy should be seen in a multidisciplinary clinic where there's a radiation oncologist present who can actually discuss what is the best decision and was an evidence-based used for the decision. But in this case, as is very common, they were referred directly by the surgeon for radiotherapy. Now, when the patient came, she was extremely anxious. It was discussed with her that her prognosis was very poor, that there would be difficulties maybe with the treatment, but she was very anxious. not to accept that decision, and she wanted to have some treatment carried out. So the radiation oncologist agreed to actually prescribe her for radiotherapy. And this is one of the very complex situations that occurs all the time, I think, in radiotherapy. So you could look at it from the ethical evaluation. The radiation oncologist did try very well to comply with the patient wishes. She was anxious, she wanted to have something done. So I think there was a real effort there. But of course, it was non-compliance because there was no evidence-based. There is evidence for melanoma treatment, but not in this context. And ultimately, it was going to do the patient more harm than good, which would lead you into beneficence or non-maleficence, because this would have very poor outcomes and would be a very difficult situation. The radiation oncologist did try to be as transparent and as honest as possible and to include her in the decision making. But again, there were some problems in terms of that, because you can be very inclusive, but if the patient refuses to accept the actual reality of the situation, then that can really be very difficult. So maybe this was quite an extreme one, but we do face this all the time in radiotherapy if it's a referral specifically, rather than an MDT where the radiation oncologist is there from the beginning and can make that decision based on the evidence. Can I have the next slide, please? And again, you can look at maybe the next one as well. You can look at the dignity and autonomy in that kind of way, or you could apply any of the others, but I chose this one. So yes, they had discussed the role and had taken the patient wishes into the decision making, whether that was good or bad. And they did consider and explain to her the benefits of the procedure, which actually weren't consistent with the patient's own goals of care. So this is where you have a real ethical dilemma, because you know that this isn't going to have a particularly positive outcome. The next slide, please. So going on from that then, you have the problem in radiotherapy where, not a problem, but the field is changing very dynamically, and you have new options for treatment that are coming on board. And generally, they tend to be highly advertised. So you get the population being aware that there's a new approach to treat something. But this was a child with a diffuse brain glioma. So therefore, there was a very poor prognosis associated with that. Treatment would have maybe an immediate but short-term effect, and long-term, there was a very poor outcome. The family had very modest means, and they had very limited health insurance. So there was a resource issue associated with that. They also had other children, so they had to consider how they could manage them. And their local department had high energy treatment units, and they could start the patient immediately, and that would have a great benefit. It was within their health insurance potential. They could manage their own children. They could make the daily trip for treatment without it being particularly difficult. But the oncologist felt that because protons were available, and available quite distant to where they lived, and also weren't within their health policy, insurance policy, but because protons are known to be very beneficial in treating children, that you get less side effects and less long-term problems, he felt it was necessary to discuss that option. So, and that's really something that you come across, and I think that in radiotherapy, we have to talk to patients quite openly about that. But of course, they will be swayed, I suppose, by public feeling as well. And in doing that, and in trying to open all the options, I think there was big compliance with beneficence and non-maleficence. But there was also some non-compliance in not being very clear that the option to have treatment locally would be more beneficial. And again, they were, in this case, very transparent, they were very honest, and they were very inclusive and understanding of the difficulties that the family were encountering in this particular scenario. The next slide, please. And again, you can look at the actual values of beneficence and non-maleficence in this particular incidence, you know. So you could say, well, does the procedure provide a medical benefit? And theoretically, yes, because you have less long-term side effects. Does it have a psychological benefit? That very much is an imaging issue. And is there a conflict between what the medical team think is the best course of action and what the patient would like? And obviously, in this case, there's a slight conflict, because in opening the option to protons, then the parents are under very significant pressure to feel that this is an option they should pick for their child, where the medical team probably are very appreciative that the local high energy treatment would be better in the short term, and the long term situation is poor anyway. Next slide, please. And again, and I have seen it quite a lot, that people will introduce new technology, and particularly where resources have been poor, new departments, new equipment is put in. And because it's very expensive, sometimes people don't consider what sort of accessory equipment in terms of immobilization equipment, masks, different setup aids that will be required. And in this case, the department was upgraded. They had 2 new linear accelerators that had multi-leaf collimation, so they could really tailor their treatment approach very closely to the actual tumor. But the tender didn't include any accessory equipment, and it didn't include any immobilization equipment. And in addition, the staff had limited training. Their previous equipment had been very old, with very limited ability, and there were no high-tech sort of plans available. And they had no experience with the new equipment. But again, and particular with physicists, that this was a new piece of equipment. They could produce very complex plans. You could have a beautiful dose distribution, and it looked very effective in treating the patient and minimizing side effects. But they had 5 fields. And anyone in radiotherapy who has tried to set up a very frail lady with no immobilization equipment, where you cannot stabilize the head, will know that to give 5 fields is effectively impossible. So there were a lot of ethical issues here, and they were mostly non-compliant. Non-compliant with dignity and autonomy, because it simply wasn't possible to put this patient into a treatment position that you could reproduce. They did try in terms of beneficence and non-maleficence, because of course this type of treatment would give you a much better outcome, but not if it can't be carried out correctly, because you would end up irradiating more normal tissue than you should. They didn't really explain to the patient what might be the outcome of an incorrect treatment in this situation. So they really weren't inclusive or empathic. The next slide, please. And again, you can use the sensitizing questions. And if you don't find them because they're written in a specific way, you can always look in your own department at the kind of issues that arise for you and apply your own maybe questions to see if they might be applicable in this setting. Next slide, please. And again, education is particularly important, I think, in radiotherapy and in understanding exactly what happens when you irradiate a patient. And people can be very well-meaning, but it doesn't necessarily mean that they're giving optimum treatment. And I think it was something that was referred to earlier by Chico in terms of physical privacy. And this is an example of this. So Mark Gentian was a 50-year-old man with early stage prostate cancer. So absolutely excellent prognosis. And he was referred for curative treatment, so high dose intensity modulated radiotherapy. Now, this is very coned to the actual tumor volume with minimal dose to the surrounding tissues. So what is absolutely essential is that the patient position is replicated every single day, or else you're introducing real error and potential damage to the patient. So on the first treatment setup, because the radiation therapists were very aware that it's uncomfortable for patients to be effectively semi-naked in a treatment position, that they allowed him to just pull his trousers and underwear down to the level of his upper thighs, just exposing then his pelvic area. And that was in order to make him feel more comfortable so that he would be able to repeat the treatment every day and try to minimize his embarrassment. But of course, if you look at that scenario, it's absolutely impossible to replicate that position the next day and the day after and the day after. So they were actually opening him to an incorrect treatment in that instance. So our radiation protection. So if you look, they were trying to comply with dignity and autonomy because they were very much considering the patient and how he felt. They were trying to be as kind as possible, but non-compliance with actually the aim of the treatment, which was to replicate it on a daily basis. And they were inclusive, but possibly through lack of understanding, they weren't able to explain fully why it was necessary to remove the trousers completely. Next slide, please. So you can again look at your sensitizing questions. Did the staff at the time have enough knowledge about the uncertainty? They probably didn't, or they wouldn't have chosen to do that. Next slide, please. And again, this is something that does occur, and this was the failure to disclose an incident or a near incident. So Aisling White was appointed as a physicist to a radiotherapy clinic. They did quite a lot of high dose rate brachytherapy, of which she had no practical experience. She had attended lectures, but she had never actually been participating in that procedure. And one of her colleagues was out sick, so she was asked to plan a high dose rate treatment. She was a bit reluctant, but again, the patient needed to be treated, so she went ahead and planned it. And 2 days later, she realized she'd made a basic mistake, and that led to a mistreatment. Now, she was probably afraid of what her colleagues might think, so she decided that the error wasn't significant and she didn't need to report it. You also have it in some instances that your whole purpose in treating patients is to do good and not harm. So there's a real psychological influence there in terms of actually saying, I made a mistake. And there are many papers in the literature that discuss that quite frequently and in depth. So there was compliance to some extent because she felt she had to do this, that the patient needed treatment. So she was trying to do it. She did more harm than good, and certainly in not reporting her error so that people could investigate, see how it happened, and actually prevent it maybe the next time. And she certainly wasn't inclusive or empathic either to her patient, who was never told that they had a mistreatment, or also to her colleagues. So she obviously was totally non-compliant with transparency and honesty in not acknowledging what she had done. Next slide, please. And again, you can apply your sensitizing questions to review this, because again, this is something that you can use in your own department and you may come up with completely different answers, but it gives you something that you can look at. So, I mean, again, our resource is limited. This is very similar to a situation in Scotland many years ago, where there was a mistreatment due to somebody inexperienced planning. So these are very real scenarios. Next slide, please. So in conclusion, I think ethics for radiation protection is very complex. And we looked at the 5 of 10 scenarios and discussed them in the context of the value pairs, but you could look at the other 5 in your own time and decide for yourself. The sensitizing questions, I think, are very useful to guide you on what sort of elements you might look at in more depth in terms of the scenarios. But really most or all values could be applied to any of the scenarios. And I think it helps to give a moral assessment of practice and the ethics that underpin all the decisions we take and all of the way we practice every day. And ethical analysis is key to shared decision-making and inclusivity. And I think that's inclusivity with your colleagues as well as with patients. And it's also key, I think, to a patient-focused approach. I think that's the last slide, is it? The next slide. Yeah, I mean, these again are the publications that Jim referred to. So thank you very much indeed.
Thank you very much, Mary. I hope this gave a good insight on radiation therapy for everybody. Now we are reaching almost the end, but I think if it's the end, it's also because it is really important. And actually, yes, I wanted to share my screen. So now it's time to talk about education and training, because it's a nice story that we just discussed right now, but if it's not taught to the people who will use it in practice, it will be useless. So that's why it is important that Kimberly Applegate will be able to talk about the way we propose to teach this kind of subjects. So Kimberly, you have the floor.
Thank you, Francois. And I really appreciate all the prior presentations. I want to make sure everyone can hear me.
We can hear you, Kimberly, perfectly.
Great. So I want to thank Marie-Claire Cantone, who's the co-chair of this task group and a member of Committee 3, and also the writing group for this section of the report, which included Marie-Claire, Mary Caffey, Bernard Le Guin, and Maria Perez. So this section is the final section in the document, and it includes education and training of all relevant stakeholders. And that includes a little bit of background and introduction, and then education for the engagement and empowerment of patients, families, and caregivers with a key message. We talked about key messages a little bit, but I think it's important that up to this point, where there were 27 key messages, I'm going to talk about the last 3 key messages in this report. And then we talk about, that's the bulk of this beginning section of section 8, and then educating and involvement of the other stakeholders. And then section 8.2, elements of ethical education and training in radiological protection in medicine, with 2 other final key messages. And we have a couple of tables, which Francois alluded to, which is the taxonomy of learning, and then example of knowledge, skills, and competencies based on the scenarios that have been presented, and then a short conclusion. So let's jump right in and look at the key messages in the sections, which are 26, number 26, which are boxed, so you can find them easily. If anyone's looked on our website, you can open the draft. Message 26 starts with everyone in the diverse group of relevant stakeholders is responsible for assuring strong radiological protection and ethical values in healthcare. Each target group needs to be empowered and educated to ensure that patients are imaged and treated correctly. Message 27 says, although it may be of value to integrate the ethics teaching into everyday practical education, and it's often the case, it is also necessary to provide specific practical teaching on ethics. And this is, examples are provided, references are provided for this. And then finally, message 28, radiological protection campaigns have improved radiation health literacy for the consumer and provided transparent ethical values for all stakeholders. And Chico, in her presentation, mentioned, for example, image gently and image wisely, but there are others. So one of the important things to know is current medical practices are not uniform. And we want to provide maybe some standardized international guidance. And so we want to start with each radiological professional must have some sort of foundation of knowledge, skills, and competencies in their area of expertise, be they a medical physicist or a radiologist, a radiation oncologist, a radiographer. And that is outlined to some extent in publication 113, but also in some IAEA documents, so that they can practice safely and effectively. And we note that this must continue throughout their career. And we make a point that the employer should support ethical training when they're employed throughout their career. And we also note that there is wide variation in the kind of ethical education and training that radiological professionals receive. Yet it's essential for ethical behavior and effective communication with our medical teams and with our patients and families. For example, when we talk about benefit and risk. So let's dive a little deeper into key message 26. We want to move, as has been discussed earlier, from authority-based decisions to shared decision-making with all of our stakeholders, most especially patients and families. And our ethical basis for this is being honest, both about what we know and what we don't know. And I think that's hard when we think we should always have the answers, when indeed we do not. And then we want to be transparent. That requires that we ask questions, as Lynette Reed presented, sensitizing questions, asking folks, do you understand what we've talked about, or have you brought questions to this discussion that you have? And then all stakeholders require knowledge of ethics, and we want to remember that this is locally practiced societal values or family values and expectations. And I'll just read you a quote from the text at this time. Ethics is an essential component of an effective and balanced radiological protection, education, and training that enables informed decision-making and helps achieve the greatest possible benefit at the lowest possible risk. And so we want to tailor that education for each group. Some groups will need extensive education, and others will need, sort of go with the education as is needed at the point of contact. And then I just have a bunch of references at the bottom of the slide, which are provided throughout this chapter. In terms of teaching ethics, the key message 27 touches on the need to provide dedicated, but remember, practical ethical education. So we provide earlier in the document, not in this end chapter, but in the first few chapters, some history of development of ethics and some sort of problematic history sometimes, where people can read further into the past of medical ethics and radiological protection ethics. But we also need to be practical and provide some really nice, easy things to do to try to be balanced and to arrive at an answer that doesn't stop you from moving forward. And so we want it to start in the undergraduate years, this education, but to last throughout your professional careers. We want to note that societal and patient values are not static. We evolve in our values, and that there will be ethical dilemmas throughout our work life. It's a guaranteed occurrence. And I think some of the Q&A questions have already come up about certain dilemmas that, and we will note in the Q&A time that indeed, you can't always separate occupational and patient dilemmas. But I would submit that patient ethical dilemmas, if we focus on them, we also are able to help with occupational dilemmas. And so we talk about how to process these day-to-day work-life dilemmas with this balanced way of breaking down the issues with the tables that have been talked about, and then arriving at a solution, but there's no one right answer. And that's another question that came up in the Q&A. It all depends on many factors, which include the patient's values and the resources available at the local facility. So again, many references, and there are different ethical training programs, some of which are online, in which to proceed and provide education. Another point provided in key message 28 is that improving health literacy of patients and families is possible and has been measured, and it improves outcomes in patients. So radiological protection education and awareness campaigns like EuroSafe, LatinSafe, and just providing brochures of information or websites for patients to learn more about what we do helps them with their anxiety, but also with their decision making and engagement. So this has been shown in a number of different campaigns, and their websites provide some of the research and surveys done. But also note that facilities are responsible for this education, and public education campaigns by governments are also responsible. And then all stakeholders have a role in ethical, safe, and appropriate use of radiation in medicine. And Chico, I think, brought up the patients' rights. It's an earlier part of this document, but patients also have responsibilities to listen to the experts in the facilities providing imaging and therapy, and to understand why something is offered but something else isn't. They may have expectations they're going to get a treatment when in fact it may not be the right treatment. So they don't need a CT sometimes, and they have to listen to that, to the whys. So there's also a discussion in this section about non-patient facing workers like administrators, medical clerks, regulators, and vendors, about why it's important for them to have an ethical foundation in the workplace. So I want to turn to the second table, which is really important, and key message 29, which is an understanding of the basic principles of radiological protection is an absolute prerequisite This understanding is necessary but not sufficient without also including ethical training for all health professionals working with radiation for the purpose of diagnosis or treatment. So we want to say that this is really important. If you want to practice in your work, you got to know what you're doing, and you have to keep checking back and making sure that you're competent as you move forward in your career. So I think this has been touched on by Mary Coffey and others, and also Benjamin Bloom and colleagues many decades ago devised a hierarchical taxonomy to classify forms and levels of learning, and learning at a higher level is dependent on having acquired the prerequisite knowledge and skills at lower levels. Now, my slide is nowhere near as elegant as that presented by Francois in his introductory presentation, so I will not go into any details, but I will tell you that it's been revised and it is used not only in teaching about learning and about learners, but the important point is that it's also a way that we can measure learner outcomes, and we should measure learner outcomes so that we understand that competencies can be checked. We can understand how are they learning, and ask for feedback from learners. So this is brought up in this section. And key message 30 is that, well, I think we've covered what this section covers. So we want to talk about in the last part, which is a large table presenting an example of knowledge, skills, and competencies framework for ethical training. And it provides definitions of the ethical values, sensitizing questions, and case scenarios of the table. And we feed back into different sections of the document to give examples of what we believe a learner should understand in order to, for example, understand beneficence and non-maleficence, the core values. So if we were going to say, what should you know? What should your knowledge base be? We believe, for example, that they should have be able to define the ethical values of beneficence and non-maleficence. They should be able to list the benefits of performing a given procedure, say a chest X-ray, for a given clinical indication. They should recognize any radiation risks associated with a chest X-ray, for example. And then when we move to the middle column, we look at skills, and a practitioner should be able to determine the value of beneficence and non-maleficence that can be applied in the process of justification, explain benefit and potential harm associated with the procedure, and ask the patient what they understand about the procedure. And finally, in the last column, we look at competencies and ask the practitioner if they apply the value in recommending its management, and then in their communication. So I think this is a way that each of the paired values is brought up in this table in the last part of the chapter. Another example is how the knowledge, skills, competencies are used in inclusiveness and empathy. And we just look at, say, the competencies in the right-hand part of the slide. It asks, for example, to empower the patient in making a decision with respect to the proposed procedure. Can they do that? We ask the practitioner, can they implement patient and public engagement plan? And does the facility, does the person or the facility provide inclusiveness of patients and families? So do they have a plan? Can they demonstrate communication? So in conclusion, these guidelines, these learning strategies, and the number of references are meant to provide general information that may be adopted, but then locally adapted. I think there was a question or comment about that during earlier presentations. These case scenarios are for group discussions or individual review and reflection. And finally, this is mainly a longitudinal approach to integration of ethics and radiological protection into the medical curriculum, starting at the undergraduate school level, but also continuing throughout a professional's career. And I think with that, I should stop so we can move to the last part of the session, which is, thank you.
Which
Dr.
is
Francois.
which is question and answers. Thank you very much, Kimberly. Was really the end we needed in this presentation. Actually, we received quite a number of questions. I tried to put them in an order that can be answered from my point of view. It's well, it's maybe not the most logical, but we'll see. So I'll take the questions and I'll try to ask my colleagues to answer if they could. So maybe the first thing that was discussed in this question and answer was about the word compliance that we use in the scenario. And one of you asked if this was a suggestion that what is written in this document is actually something that can be taken as being a God word and finished. Obviously, this is not the case. And actually, in our report, we put a caveat, and I can read it to you. We say that regarding the tables and the scenario and what we call compliance and non-compliance, we say the gradings in the table do not necessarily provide uniquely correct answers. However, they are a starting point for discussion and further review by the reader. Readers may also find the scenario provide a useful starting point template to help generate new examples based on their own experience. Okay, so I think this is clear, but maybe Lynette would like to add something more, because this was a discussion within our working group. Is the word compliance correct? And maybe Lynette, you would like to add something?
I can't start my video, but I think, Francois, you've answered the question, and it was a discussion in the group and other words were considered. It would be, I think, of interest to the group if the public feedback is that the word compliant might be misunderstood in terms of strict regulatory compliance, then perhaps that's what public consultation is for, and the group can reflect on that. Other words would be possible, like you could say the scenario is consistent or inconsistent with different values, and that might have a different flavor. Thank you for the feedback.
Okay. Thank you, Lynette. Another question that I have here is about pregnancy. It's, or if I just summarize, it's a situation in which a woman may know that she's pregnant, but she doesn't want anybody else to know, but she has to proceed with a nuclear medicine examination. And I think, Shieko, you wanted to answer this question and to discuss this situation.
Yes, my perspective is that I don't want to say that it is non-compliance, because patients have also the responsibility to disclose the necessary information to receive some kind of treatment. So I would like to stress the patient responsibility on this point. However, I discussed with Lynette in chat that there would be some cases that this patient needs some specific treatment. So in such case, there would be better to, there would be the cases it is better to provide to this patient some specific treatment, even if this patient doesn't disclose her situation of pregnancy. So it is up to the case of disease and relevant treatment and the risks and the benefit. But my point is to state that the patient also have a responsibility to receive the treatment and disclose necessary information and to protect her fetus, as well as a consideration about the partner or father or the other related family members. I would wish to say this patient responsibility in the situation of shared decision making.
Thank you, Shieko. Does anybody else from the task group wants to comment on that? No? Okay, thank you. Another question was about research, medical research, because sometimes the frontier or the border between usual medical practice and clinical research is a bit fuzzy, and the question was how did the task group deal with that? So Kimberly, I think you mentioned that you may have an answer for that.
Yes, we have a new task group 126, and this focuses on human research and radiation protection. So it updates a prior publication. So we're not doing that in task group 109.
That was actually a recurrent question at the beginning. Also, it was not in our terms of references. Several times we arrived at the border and we thought maybe we could include some part, and finally we decided to do this in the other task group. Yeah. Anybody? No, I don't see anybody who would like to add something. There was another question about whistleblower, and the question was more or less how do we deal with whistleblowers? That means professionals of medical imaging, for instance, or therapy, who see something that is not clear from an ethical point of view, and do we have something to say about that in our report? And Shieko, you had a suggestion for an answer at least.
Yeah, thank you very much. My point is that the management of whistleblowing is one of the very important factor of the safety culture, patient safety culture. And I discussed about the radiation safety culture should be in line with the more general patient safety culture. So it is very important to the organizational structure to include the protection of the whistleblower, and at the same time, it will be very important to no punishment on honest medical error. So this kind of organizational structure is very important, and I think that there would be some cases that the punishment is necessary. However, it is very important to share the information of the risks of some cases that maybe the information is coming from the whistleblower. So that is a point I would like to answer to the question.
Thank you, Shieko. Fred, you want to add something?
Yes. Yes, there's sometimes in some institutions, I think, an appropriate operational structure that allows in the middle of a procedure for members of the care team to say, can we just take a pause here, because I have a concern and I just want to bring it up to make sure before we move forward. And that I think that that less senior members of the team need to be respected in this regard, because they may see something that they want to question, and not to have their also not to have their concerns ignored or punished because they're holding up things. So I think that kind of respect of the team members also has to be considered in the same context.
Mary?
Yeah, I was just saying more or less the same thing. I think it depends on the culture, and you need to have a culture in your department that is quite open, but also sees reporting as a tool that you can learn from. So turning it upside down, that then you're not blamed for reporting if you see something, but you see it as an opportunity to learn and prevent it again, or to change your practice. So I think it comes back to seeing it in that terms. And most of the reporting systems in radiotherapy don't use the word reporting. They're all learning systems. So I think it's shifting that culture.
Yeah. Thank you. Okay. Another point I have is the relationship between regulators and ethics. And somebody asked us if we have any scenario in which ethics may suggest a different action to that dictated by the regulators. And Lynette, I think you had a suggestion for this question.
I thought it would be useful if, sorry, I've lost that question in the queue there, but if the person or any of us could say what would be an example of that, we can look through the report and see if we've addressed it,
Okay, sorry about that. Jim, you have an answer. You're muted, Jim.
I think it may be no harm to try and highlight the issue in one specific scenario, but in almost all the scenarios, there are areas where ethical behavior and legal behavior aren't coincident, mainly because the scope of law is much less than the scope of ethics. That many of the issues we look at, for example, there are very few laws around empathy, and so it's necessary not to lose the, if you like, the breadth and the distinction of ethics being something that runs through human behavior, whereas the law is quite restricted in its scope.
Mm-hmm. Okay, thank you. Oh, Kimberly.
Well, I wanted to answer a couple of questions that have come up toward the bottom in case that we don't get to them, and that's the couple of comments have come up about who, if the patient has no understanding or of implications of ionizing radiation, who should make the choice? Well, you know, I have dealt in my career with children and parents, and there's a wide range of whether people understand, you know, what radiation is. And, you know, I think that's a little bit authoritarian or patriarchal, and we're trying to get away from that. So I think it's our duty to educate everyone. We don't get a pass. And so that comes up in the document. And the other thing is that, you know, how many of us on this workshop today are putting the radiation dose into the medical record. That's something we recommend. So I just ask that we think about what our ethical values are and what our duty is to educate always. And so that's what we do. And, you know, it's just taking a moment to compare it to something that they're familiar with. And it's not about a legal thing, it's an ethical thing. So that ties nicely into, you know, justification. Who's responsible? Well, we have to justify everything we do. And so that comes first, and then we optimize, right, in our principles of radiological protection. And then the other question that came along was informed consent. Do we provide informed consent? And the quick answer is we're not recommending, you know, a legal stance. There are regions of the world that have informed consent for radiation, but that's not where we're going. We're saying provide shared decision making, provide education, and communicate. Thanks.
Thank you, Kimberly. And that leads us easily to another related question, which was the question of somebody, of a patient who may have some problems to really understand and make a decision. And at the end, this patient may ask the practitioner, what would you do yourself? And Lynette may propose an answer to this question.
I'm sorry, Francois, I was typing an answer to somebody else's question. If you could just in 2 words.
It was the question, what would you do yourself, doctor?
Yes, what would you do yourself, doctor? There's been some further discussion of that in the comments. It's very important that not all patients want to take the completely consumeristic, autonomous view of their own role in decision-making. So research studies suggest that a percentage of patients prefer that, a percentage of patients prefer pure medical paternalism in the old sense. And most patients in between want help from the physician in interpreting information, what matters for their context, what matters for their own values. So it's that interpretive conversation that people might be looking for. You might be with the 10% who really literally want you to make the decision for them. That's another question. But with that group in the middle who want help interpreting, you could answer the question or not in terms of what you would do, but whether you answer it or not, what you want to do is you maybe answer it and explain why you would make that decision, like what matters to you, what context, what resources you have in your context. Or if you don't answer it yourself, because it's your own personal information, what you would do in this situation, you might say, well, I've seen patients make different decisions. And don't just tell them the different decisions, but patients can really be looking for help in interpreting. So like all of us, if we just give you a bunch of principles, you would look to us for help in interpreting them. Same thing for your patients. So you give them the information, but well, some people find that it's easier to organize childcare if they do it this way. Some people find that at this point, they're really wondering whether continuing treatment is worth it and whether they should consult with palliative care and start to think about changing their goals of care. Those are very, very different conversations. The 2 I suggested, it really depends on your clinical scenario there, what situation you're in. So helping them interpret why they're looking for that information from you can be important. Now, for that 10% who really want you to make the decision, there's actually an excellent article in the oncology field about how to work with patients who don't want medical information and who don't want the decision-making role. And that's a bit of a longer-term process because sometimes people might not want that role, but really eventually they have to either come around to having that role or they have to find supports in their own life. People like substitute decision makers, supported decision makers who can help them take that role, because at the end of the day, you as the provider, depends maybe partly legally on the jurisdiction, but at the end of the day, ethically, you can't really make life or death decisions for other people, right? So, it's. I hope I've given you sort of a sketch of how you can kind of triage that and think there's different kinds of reasons the patient might be asking that. There are different approaches I could have depending on. But it is important to sort of find out from the patient where they're coming from and why they're asking that question, for sure.
Yeah, thank you. And for the broader question of consent, I think Mary and Sheko, so maybe Mary, you wanted to add something?
Yeah, no, well, I think I'll respond first to Lynette and Kimberly, and I agree you have to try to involve patients as much as possible. But in the end of the day, not everybody can know everything about everything. So, you know, if you go to a solicitor, you don't expect to be able to give an equal input into it. So at some point in time, you really need to advise patients as to what are the best options and then help them to decide which one. But what I was somebody has asked about the ethics of using tattoo points in radiotherapy, which is very specific, I know. But I think it comes back to that balance. If your patient really objects, you have to look for a different way. But the whole point is explaining that the tattoos actually enable you to make sure that you're treating them in the same position every day. And so I think that's it's explaining why you're doing it rather than just rushing in and tattooing them.
Mm-hmm. Yeah, thank you. Sheko?
So thank you very much. So I would like to say a little bit about the answering to the question whether or not a written explanation and consent is necessary for radiation dose. In practical setting, written explanation and consent is not necessarily required for a very low radiation dose exposure, while the written explanation and consent is required for higher dose radiation exposure. So I don't think that there are any international standards on how much radiation dose require written explanation and consent. However, my personal opinion is that written information about the radiation dose is necessary if there is a possible risk of harm. I believe that most of the patients cannot understand the implication of the risk of radiation dose immediately, only listening to the explanation. For this reason, based on the written information provided, patients can consult with family members or external experts. For this reason, written explanation is very much important in case of higher radiation dose. So that's the point I wanted to add. Thank you very much.
Thank you, Sheiko. I just realized that we passed the time we were allowed to have our webinar. But anyway, I'd like to ask the panelists if there is still one urgent question you would like to answer. If your question has not been answered, they will be answered afterward in the question and answers and then distributed after the meeting. But anyway, if anybody from the task group wants to take a subject that is really important that we did not address. No, I don't see any. Yes, Fred.
Just quickly, you pointed out early on that, the use of ionizing radiation in the context of medicine is unique, perhaps, in radiation protection because we are intentionally irradiating people. But I think in some ways, some of the issues we've been talking about are not unique with respect to other medical treatments. That there's a number of medical treatments that have some risk associated with them, if when they're used, but also have some benefits. And it has to be presented, I think, to the patient that it has both of these and give them the information that they then can try to as best they can. They're not going to understand all the complexities, but they can understand it at some level, and then they can perhaps make the best decision that they can make then.
Mm-hmm. Yeah. And John?
Yeah, a very quick comment. Many questions were related to consent form, and I just wanted to highlight that the purpose of these forms, consent forms, is to ensure that patients have the necessary information to make informed decision about their health care. So by signing these forms, patients in fact acknowledge that they understand the procedure, that they procedure risks, and it also serves as a documentation of the patient's consent, which can be important both from the legal point of view and also from the ethical point of view. Thank you.
Yeah, that's important. You're right. Thank you. So that means we arrived to the end. I noticed that we were most of the time more than 250 people attending. So I hope you appreciate it. And the only thing I'd like to mention again is that in order to apply the inclusiveness value, we ask everybody to take part in the public consultation. And if you want to do it, you have until August 11 midnight, I think. So try to do it maybe before midnight, we never know. But I would like to thank all the presenter, all the members of the task groups, all those who already gave us some advice during the meeting, the previous meeting we had, and again, to all of you who may contribute to the public consultation. So I think I just need to tell everybody goodbye. And if I don't see you again, I wish you a very nice summer if you're in the Northern Hemisphere. Okay, bye-bye. Thank you very much.
Bye.